Ladies and gentlemen, our program will begin in 2 minutes. Ladies and gentlemen, please take your seats. Our program is about to begin.
Good afternoon. My name is Angela Kim, and I am Senior Director of Economics and Health Policy for the ACR. On behalf of 14 incredible economics staff, it is my pleasure to welcome you to this year's Economics Forum. This forum is a highlight of the ACR annual meeting and a chance for the ACR to showcase its economics activities on behalf of our specialty. I'm pleased to introduce the moderator for today's activities, Dr. Zeke Silva. Dr. Silva is the chairman of the Commission on Economics for the ACR and is engaged across the spectrum of radiology payment policy. On the fee-for-service end of the spectrum, he is a member of the RVS Update Committee, the RUC, where he helps to formulate recommendations to the Centers for Medicare and Medicaid Services regarding updates to the Medicare physician fee schedule. He is also engaged in creation of new payment models. He served on the CMS Acumen Resources Use Measures Committee and was recently appointed to the MACRA Episode-Based Cost Measures Clinical Subcommittee. He is a member of the National Quality Forum and the AMA Medicine Payment Advisory Group. Please join me in welcoming Dr. Silva.
Let's go back in time. Let's go back 30 years. Let's go back to 1987. The song, With or Without You, was the top of the Billboard charts. Beverly Hills Cop 2 was the tops at the box office, and healthcare payment policy reform was on the horizon. Almost to this day, on May 13th, 1987, with the support of our college, then President Joseph Marasco from Pittsburgh goes before the House Ways and Means Committee. He was one of 12 specialties discussing a potential new payment model. At the end of the testimony, the chairman of the committee, Pete Stark, looks at the witnesses at the table and asks, who volunteers to help the government create a new episode relative value scale for physician payment? One specialty, one society volunteered. It was the American College of Radiology. As a result of that effort, the system which has defined our payment for the past 30 years was created, a system which by most measures has been favorable to this profession. It's allowed radiologists to remain independent and engaged in healthcare. It's allowed innovation to occur, and it's allowed patients to have access. I have the privilege of chairing a commission, 15 full-time employees, over 740 volunteers. We review thousands of pages of documents and produce thousands of pages of documents every year. We take our job very seriously, and we're very good at what we do. But I would argue the real task of the commission, and frankly the real task of the ACR, is to guide our members, is to help our members navigate through what I believe is currently a similar, and I'm going to borrow Jeff Emmelt's terminology from yesterday, a similar pivot point in our profession. I have the privilege today of welcoming, over our two-part forum, 6 dedicated volunteers, each of whom will discuss their efforts individually and among those they lead to help our profession navigate that spectrum. And at the most basic level, one could call it volume to value, but I want to make an important point. It is not one replacing the other. It is a spectrum of activity. It is a transition. So we will talk today about volume-driven care. We will talk today about fee-for-service. But we will also talk about that transition to value and how we help those who are touched by the radiology profession navigate that spectrum. And it is radiologists. It's radiology professionals. It's every one of us in this room, but it's facilities. It's academic departments. It's policymakers, and it is patients. So with that introduction, it is my pleasure to welcome our first speaker, Dana Smitherman. Dana is the Vice Chair of Radiology at the main campus for Ochsner in New Orleans, Louisiana. She is the Chairman of the Breast Committee under the Commission on Economics. And I know Dana, I've known her for several years, but I first met Dana when we were working on coverage and coding and valuation for tomosynthesis. And we're at the table. And it was going, we're at the ruck, we're talking valuation for tomosynthesis. And it was going well. But as soon as Dana began to speak, the tide got even better. Because Dana not only understands coding, she not only understands valuation, she understands the science, she understands the literature, she understands the importance of patient care. And that became quickly evident, and it's led to the successes we've enjoyed, and is also critical to the challenges we faced in breast imaging. Please join me in welcoming Dana Smitherman.
Well, good afternoon. I would like to thank Zeke and the Commission for inviting me to speak today on a topic that is not only of great importance to me, but I suspect that it's of great importance to many of you out there, and that is the economic state of breast imaging. So in the 20 minutes that I am speaking with you today, 10 women in the United States will be diagnosed with breast cancer, and 2 women will die of the disease. Nonetheless, breast cancer mortality in the United States is an enormous success story. It is one of the success stories of modern medicine. Since the late 1980s, when screening mammography became commonplace in this country, we have seen a 37% decrease in breast cancer mortality. And this is not just a victory for our patients and for our clinical colleagues. This is a victory for radiologists and the American College of Radiology, who have fought tirelessly to have access for high-quality mammography to all of the women of our country. We now have a 90% 5-year survival for breast cancer. In 2016, US radiologists interpreted over 39 million mammograms in over 17,000 mammography units, in over 8,700 ACR accredited facilities. Nonetheless, despite these victories, despite that 37% decrease in breast cancer mortality, access to high-quality mammography in this country is in jeopardy. I would like to paint a picture for all of you about basically where we are, the current state of mammography reimbursement, threats, and these are real threats to mammography access, and then also challenges to our progress and what we need to do to protect our patients. I hope to provide all of you with basically an arsenal of facts to arm you if you ever need to stand up and advocate for access to mammography. The picture, this is 1999-2000. Radiologists are sitting in dark rooms at alternators. We're looking at films. We're using magnifying glasses to look at mammograms. In 2000 and 2001, things change. We get FDA approval for digital mammography, and Congress enacts the Benefits Improvement and Protection Act, or BIPA. CMS creates G codes for digital mammography with the same professional component reimbursement as analog codes, but the technical component reimbursement is set at 1.5 times the reimbursement for analog. 2003, we go through the process, we get the codes revalued for film screen mammography and for the new CAD. And then in 2013, 10 years later, the Relativity Assessment Work Group of the RUC identifies the digital mammography codes as potentially misvalued. Then, in 2017, we created new codes, bundled codes, for mammography and CAD. These are the reimbursements as they stood from 2003 to 2016. And you will notice that the professional component for screening and unilateral diagnostic was 0.7. These are the professional RVUs. And for bilateral diagnostic were 0.87. The top of the slide is basically the film reimbursement. The bottom of the slide is the digital, and you'll note they're the same. Plus, there was a small additional PC RVU, 0.06, for CAD. Here are the new mammography codes that were created in 2017. And you'll notice one very distinctive thing, and this is in great contrast to many other bundled codes that have gone through the CPT process. The screening mammogram with CAD when performed is 0.76 RVUs. This is the direct sum of the CAD and the mammography CPT code RVU, PC RVUs. The diagnostic mammogram codes, however, actually have a slight increase. And that is a credit to the people in this room, to the radiologists throughout the country, who not only provided interpretation, but also added value to the care of those patients by navigating the patients, by giving the patient their results, whether that was good news or bad news. Unfortunately, on the technical component side, the news was not as good. If you remember when BIPA came through, the reimbursement for digital mammography on the technical side was 1.5 times that of film screen. Now the codes went through the standard CMS methodology and the standard valuation. If those codes had been enacted in that manner, that would have resulted in a 50% decrease in the technical component RVUs. To their credit, CMS recognized that a decrease of this magnitude could cause a serious impact on access for mammography in this country. The ACR shares these very real concerns. Nonetheless, they intend to revisit this issue in 2018, and the ACR has been working diligently to try to provide data to give them some idea of what this impact might be. So what would happen if United States women no longer had adequate access to mammography? Well, history tells us a little bit, and also the literature tells us some information about this. This is from a study at a major teaching hospital. They looked at their women who died from breast cancer. And what they found was 70% of those women who died were among the 20% of women who had not been having regular screening mammography. So this is one thing that happens when access to mammography goes down. If we look at history, this is another study. They looked at basically regional disease, distant metastatic disease, so regional disease, cancer that's spread, metastatic disease, cancer that's gone to the lymph nodes and other parts of the body. They looked before mammograms, 1977 to 1979, and then they looked after mammograms had become commonplace, 2007 to 2005, so 2009. And what they saw is between those two periods of time, regional disease decreased by 39%. Distant metastatic disease decreased by 26%. Localized disease that could be treated with many more options with lumpectomy and not mastectomy, which has a much better prognosis, increased. So this is what happens without mammography. What if we do mammograms every other year instead of every year? This is a study where they looked at women who were currently 30 to 39 in the United States. And they looked to see what would happen, ran models, if they had annual mammograms or mammograms every other year. So the first column is women who started at 40, went to age 84, had mammograms every year. 12 out of 1,000 lives were saved. If they only had mammograms every other year, from age 50 to 74, starting a little later, 7 out of 1,000 lives were saved. So that means that if you start mammography later and you do mammograms every other year, 5 out of 1,000 additional women will die from breast cancer. The second line is the perfect world, if we had 100% compliance, and you can see what those statistics are. The bottom line is more realistic. This is with 65% compliance. That's about what we have. And what we see is that if we run those numbers, there are 65,000 women, roughly, who would die because they had mammograms from 50 to 74 every other year. So how big is 65,000 people? It turns out 65,000 people is the size of Palo Alto and Redondo Beach, California. It's the size of Portland, Maine. And it's the size of Schenectady, New York. Or if you live in Louisiana like me, it's the size of Kenner, Louisiana. This is another analysis that looks at what if we don't start screening until age 50 instead of age 40. I'm going to draw your attention to a couple of points on this slide. So what actually happens today, these are 2010 numbers, was if we screen women as we're currently doing for screenings, workup, and biopsy, that costs the healthcare system about $7.8 billion, and that is not a small amount of money. But there are also costs to not treating for breast cancer, and I'm not even talking about societal or personal costs, I'm just talking about dollars and cents. It costs $250,000 to treat a case of metastatic breast cancer, and if a woman in her 40s dies of breast cancer, the cost in lost productivity is $1.4 million. So if you plug in the numbers of the annual cost of treating metastatic breast cancer and the lost productivity for women who die of breast cancer in the 40s, that is $13.3 billion, a number that dwarfs the amount that we're currently spending. But there are challenges to our progress. Mammography is not a perfect tool. I'm not going to stand up here and tell you that it is. There are patients who have breast cancer and it's missed on mammograms. There are patients who don't have breast cancer and get recalled and have anxiety from that. There are patients who have biopsies who don't have breast cancer. But we need to find better tools. One such better tool was digital breast tomosynthesis. So in 2015, we decided that digital breast tomosynthesis was ready for a Category 1 CPT code. It was a contemporary, widely performed practice. It wasn't just done in clinical trials at research sites. It was FDA approved. It had documented clinical efficacy, and there was literature support. Here's a digital breast tomosynthesis elegantly showing a cancer. It decreased the recall rate 15 to 46% in studies. It increased the cancer detection rate. And so we were very fortunate. We went through the entire process, and we wound up getting codes for digital breast tomosynthesis so that CMS would have payment for our Medicare patients to have digital breast tomosynthesis. Tomosynthesis is also cost effective. Just a couple of studies here that demonstrate its cost effectiveness. The first showing that if the additional cost is less than $250 and the recall rate decreases at least 6%, we'll see cost effectiveness, particularly in our youngest patients. Also, with just a slight incremental increase in reimbursement, $37 for digital breast tomosynthesis, we save $8 per patient and over $200,000 for an average state Medicaid program. Nonetheless, despite all this evidence and despite the presence of codes for that CMS approved for Medicare patients, there is still not universal coverage of digital breast tomosynthesis by commercial insurers. In response to this, the citizens of states like Illinois and Pennsylvania have decided that they needed to rise up and demand access to digital breast tomosynthesis. 5 additional states have introduced bills this year to try to ensure access to digital breast tomosynthesis for their citizens. The Affordable Care Act, no matter what you think of it, one of the big successes of the Affordable Care Act has certainly been the expansion in coverage. And in particular, the Affordable Care Act covers, with no additional expense, a group of preventive services called essential benefits. 137 million people and over 55 million women have taken advantage of those services. And what we have seen is that in states that underwent the Medicaid expansion, there has been increased compliance with screening mammography in every socioeconomic class, including the poorest. The Affordable Care Act does ensure access to screening mammography, but the current version of the American Health Care Act, which is the Republican repeal and replace, the current version that passed the House has an amendment that lets the states define those essential benefits. So what that means is we don't know if screening mammography will make the cut. So I've talked about the legislative action for digital breast tomosynthesis. We have also, as a group, the ACR and many, many others, including our patients, had to rise up and demand access for screening mammography based on some of the things in the Affordable Care Act. So the USPSTF in 2009 and 2015, and this is one of the groups that gets to define the preventive services in the ACA, only recommends screening mammography every other year from age 50 to 74. Now, so far, those restrictions have not gone into place because of the actions of many advocates, with an addendum first to the Affordable Care Act, then the PALS Act, and then currently a 2017 spending agreement. But that is only good until the end of 2018. There's another group, one of the groups that can make recommendations about what screening services should be covered, called the WIPSI. This group, fortunately, is now recommending that screening mammography should be covered with no cost sharing as early as 40, no later than 50, as frequently as yearly, and no less than every other year. So this is a more inclusive recommendation. Unfortunately, neither of these is a permanent solution. So the time may come, and that's why I'm arming you with these facts, that we all need to rise up and defend access to mammography in the United States. So in the 20 minutes that I've been speaking with you, 10 women in the United States were diagnosed with breast cancer, and 2 women died of the disease. I've taken you through our current state of mammography reimbursement and talked to you about the real threats to access to mammography in this country despite our successes. And then finally, the challenges that we are facing to progress when we try to bring forth new technology like digital breast tomosynthesis. So really, I'm preparing you, if we ever need it, for a call to action. Access to mammography in this country is jeopardized by the potential reduction in the technical component reimbursement, the coverage implications that could happen if the USPSTF guidelines are adopted, and also the possible changes in essential benefits under the American Health Care Act. Digital breast tomosynthesis, which addresses many of the shortcomings of mammography, is still not consistently covered by commercial insurers. And while mammography is a significant expenditure to the U.S. healthcare system, there are also costs, societal and monetary, related to not screening for breast cancer. So I thank all of you for everything that you have done so far with the ACR and all of our partners and our patients to maintain access to mammography. And as I said, I hope if we ever need you, you'll feel like you are armed with information to be able to rise up and defend access to mammography. Thank you.
Thank you so much, Dana. So we'll now move to sort of the next step, if you will, in our spectrum and our pivot. We're moving from volume to value. The next speaker is Kurt Shoppy. Kurt Shoppy practices in North Texas with Radiology Associates of North Texas He's a past Moorfield Economics Fellow. He's the chairman of our reimbursement committee. And for the past year, he has served as the advisor to the RVS Update Committee, the RUC. You might recall, that was my prior position. You may recall, that was Geraldine's position before that, and that was Bib Allen's position before that. It is a very real job. So at the last meeting, now I'm on the panel, so I'm at the table. And I leave the table, and a RUC panel member comes up to me and says, wow. And this is after Kurt's been presenting for about 3 hours. He says, wow. He says, where do you find this talent? And I said, we just find it. With that introduction, please join me in welcoming Kurt Shopping.
Well, good afternoon. So we're going to talk about finding value in radiology services. And when we go looking for value, we don't always look at fee-for-service. In fact, I would say that we usually consider fee-for-service just the opposite. But there's value hidden in the fee-for-service schedule, and you just got to know where to look. And this starts at the RUC. That's the Relative Value Scale Update Committee. This is the body that makes recommendations to Medicare on what a medical procedure is worth, the RVUs. And so we're all uncomfortably familiar in this room with the fact that many of the RVUs for many of our radiology services have decreased significantly in the last 2 decades, both for the professional component and especially that technical component. All right, but something different happened this year. And to understand that and to understand how important that is, we need to take a look at what it's like to be at the RUC. And so the best analogy I have for you is a Senate confirmation hearing. Only none of the people asking those questions are in your party, and they all think you took something from them. All right? So the discourse can be contentious. And I think this was put very well by one of our clinical experts at her first meeting. After seeing the proceedings for a bit, she turns to us and goes, guys, if people talk to each other like this at my hospital and in our department meetings, they would be fired. So it's a medical fight club, and the edges are a little bit rough at the RUC, all right? And then you go to the table. And so just like the picture we're looking at, this table's big and it's square, and it is the entire width of one of those grand hotel ballrooms. And at the front of that table is the chair of the RUC, the AMA staff, and Medicare. Along the sides of that table are the RUC panel physicians, all 28 of them. And there at the end is your RUC team taking all the arrows. All right? Now, our job is to present those code values for radiology. And we do that with 2 things, clinical expertise and data. And so when we're preparing for these mammography codes, we're feeling pretty good. We've got solid data, and we've got a good story to tell. And so we go to the table, and we tell that story, and the bottom falls out. This goes from a presentation to an interrogation. The questions come fast, and they're coming thick, and they all revolve around the fact that no one believes that radiologists talk to patients. And this is when the anecdotes start flying. Well, I got a chest CT, and no radiologist talked to me. I send patients in all the time, and they get all sorts of scans, and no radiologist talks to them. It is not going well. And it gets worse and worse, and it's going around and around. And it might as well just start raining in that ballroom. And all I can think is I've got one job, and this ship is sinking. And that's when one of the female RUC members breaks in and makes a comment. And then another RUC member makes a comment. And then one of the male RUC members tells about how when he went with his wife to get her diagnostic mammogram, and you know what they all talked about? They talked about how the radiologist stopped and sat and talked with them, face to face. These voices at the RUC turn the tide, and they ultimately change the outcome. So these are not just physicians that are there speaking. They were and are our patients. And they were there to speak for us about what we do and what it means for them. And so there's value in fee-for-service. And I was there to see it at the Ruck. And that value is based on our values. That's the compassion that those mammographers have for their patients, to speak to them. And our patients, your patients, will tell our story. And when they did tell this story at the Ruck, they took a process that is very frequently frustrating, one that can really wear you down. And they took it and they made it something that we should reflect on and really celebrate. All right? So we're going to come back to this duality of values and value at the Ruck. But right now, I want to take a moment to introduce our Ruck team. All right? These are our staff. This is Stephanie and Christy. They do a tremendous amount of work, and it is detailed, and it is tedious, and they do it with a very high level of professionalism. To wit, when we're going to survey codes at the Ruck, and we may only be 5 or 10% of the claims for these codes, very frequently other specialties look to us to lead processing that data, to put those forms together and the recommendations and to go to the table. And that comes from the foundation that is built by these two professionals. So if you see them at the meeting, I ask you, take a moment and tell them thanks. Zeke Silva needs no introduction. He's a Ruck member. He's the one that gets to vote. And without a doubt, Zeke is the smartest person in the room. Unfortunately, he can't talk about radiology codes at the meeting because of the rules of engagement at the Ruck. And that's my job as the Ruck advisor, for better or worse. Bill Donovan is Zeke's alternate on the Ruck panel. Greg Nicola is the ASNR Ruck advisor, and he leads the neuroradiology codes, and we back him up. And Dan Wessel is the ACR alternate advisor. And so you talk about a talent pool, that Zeke references, and here are residents, fellows, and young physician section members that work with us on putting these recommendations together and have been at these meetings to see the process. So I encourage you to go see what they thought about it, or reach out to them on Twitter. So we're going to talk briefly today about 3 things. We're going to look at what we've done, those codes that are now out in 2017, and why the way they are valued is important for us. We're going to look at where we're going, the 2018, 2019 codes, and what you can do to help. And then we're going to take a look into the future. And we're going to try to answer the question of what does this mean for me, and what does it mean for you as individual radiologists? So we're going to briefly look at a couple codes that are in the field now, but it's important to understand how they got their values. And we talked about the mammography codes. Now, they were bundled in CPT, but the structure of the code family stays the same, only now the computer-aided detection, CAD, is bundled into the screening, the unilateral, and the bilateral diagnostic codes. All right? These codes, as Dana referenced, go through the Ruck, they come through Medicare and finalized with increased values. And those increased values are either the same or more than just adding CAD. And I think we all can recognize that that is not the typical outcome for a Ruck valuation process. And it is very tempting to see that as the victory in this situation. And I'm going to tell you it's not. The victory is the recognition. The recognition that we do more as radiologists than just look at images. And you know, and I know, that to say a radiologist just looks at images is like saying a surgeon just cuts stuff out of people. All right? But what's really important is that it's Medicare and the Ruck, that it's an explicit recognition of that value, and that radiologists participate in the coordination of patient care, and they communicate. We communicate face-to-face with our patients. This is value, and that's baked into that increased professional RVU that you see for those mammography codes. And these activities, this coordination and this communication is also important for fetal MRI. These are new codes that came through CPT. When codes come through CPT, they go to the Ruck to be valued. So this is a new family of codes. The base code is MRI fetus, including all the surrounding structures. And then there's an add-on code for each additional gestation. And it's important now to take a step back and think about all of the work that goes into a fetal MRI. There's the initial consultation with an obstetrician to answer the question, what's wrong? What did you see? What do we need to figure out? There's the talk with mom and dad, because they know that something's wrong or something could be wrong with their baby. And they want to know why we're doing this. What are we going to do? How are we going to do it? And then we have to acquire the images. And this is a technically demanding exam. And that's frequently going to require the radiologist to be at the machine with the technologist to make sure that those images are of a high quality that we can answer a question. And then after all of that work is done, we're going to go and in consultation with the geneticist, the maternal fetal medicine specialist, and again with mom and dad to produce those answers. And so that's your value. That list of activities is value served from the radiologist. And that's why you see the RVUs associated with these codes are some of the highest in the radiology diagnostic code set. But I want to draw your attention to one detail in here that's implicit. Look at the add-on code at 1.85 RVUs. That's the additional work of reading just the fetus portion of the exam. And look at the difference between the base code. It's 1.15 RVUs. In large part, that is that additional work. That is the conversations and coordinating care across multiple specialists. That is talking with mom and dad. And 1.15 RVUs may not seem like a lot, but that's about the same amount of work that's in a level 3 E&M code for a new patient that a primary care physician is going to spend 30 minutes on. That's value. That's value that's baked in to that RVU for that code. And that's work done by your colleagues in this room. And so this work, care coordination and communication, is also important for lung cancer screening. But we look at the value for lung cancer screening, and that work is not in there yet. 1.02 RVUs is a disappointingly low value for the work that goes into lung cancer screening CT. It's tied right now to the non-contrast chest CT. But what's important about lung cancer screening is this is an opportunity. It's an opportunity for radiology as a specialty to show all of the work that we do beyond the interpretation of images. This is coordination with specialties. It's managing patient relationships. And it is communicating with the patient and using data. This is us exercising our values and our expertise in technical work to care not just for an individual patient, but to care for a population of patients. And this code, lung cancer screening, is going to come back to the RUC, and it's going to need to be valued. And I want to go to the table and I want to tell them about everything we do beyond just interpreting images. I want to tell them about how we exercise our values as physicians when we care for these patients. Now, there's a number of codes that are coming through for 2018. These are codes that have been through the RUC process, and they will be opined upon by Medicare this summer. But as you look at these codes, you will undoubtedly find something that's important to you. There's CT chest, there's MRI abdomen, MRI pelvis. That's 9 codes that are high volume, high value codes. And what you should see in this list is the hours and hours and days upon days of work that your ACR staff and your volunteers put into speaking to the value of radiology. So let's look at what we're doing right now and look at what you can do to help. So the RUC process doesn't stop. This is a never-ending treadmill. There will always be more codes to value and revalue. MRI breast is being bundled with CAD, and that is coming to the next RUC meeting. There are multiple codes and code families that are at the CPT or in the CPT process, and depending on the outcomes there, they may also come to the RUC. And you may see in this screen something that is important to you. Now let's think back. When we're at the table at the RUC, we take two things up with us: clinical expertise and data. And that data comes from surveys that I need you to fill out. The best thing you can do to help your RUC team and help your specialty is to tell us what you do. Because we take your data and your stories and we take them to the RUC. And it's an intense process. There's more and more aggressive screens. It used to be a code would get a value and it would not come up for 5 or more years. Those codes are coming up in 2 or 3 years to be revalued. A single code caught on a minute screen is going to bring in every code related to that in the family, even if those codes have been valued recently. There continues to be pressure for bundling, and there's even a lot of attention on global periods, which in essence is unbundling, because Medicare likes to have its cake and eat it too. And there is a laser focus on practice expense, and that's that technical component. And what we need to do is maintain an awareness and a perspective of the larger healthcare environment in which we provide our services. We need to know and understand the mandates of our payers. And very frequently, this is about saving money. And that gets us to the question of where are we going? And the important question that you need to ask yourself is, why is this important for me or for you as an individual radiologist? And so the future is always murky, and I just don't know where we're going to end up. There's uncertainty in regulation. There's uncertainty in politics, and the business of medicine continues to change. The science of medicine continues to evolve. All of these things are fluid. So when we look at this uncertainty, we need to look back and ask, what is fundamental? Fee-for-service is fundamental. It's fundamental to bundled payments. It's fundamental to alternative payment models. It is fundamental to constructing episodes of care. These individual codes and their values form the structure on which these future transactions will be built. These individual codes and their values are necessary for accounting, and they're necessary for accountability. And so in this way, fee-for-service is really one of the fundamental particles of healthcare finance. And so your ACR team will continue to speak to the value of our services, but our successes will be based on our values. The way we do our work day to day, the choices we make in providing care, these will influence the values that are assigned to that work later. And so this is your collective action problem. It's these thousands of tiny interactions, the patient encounters, the phone calls, that translate into the way others will value us as professionals. And I'm going to tell you, you want it to. Because like we saw at the RUC, the RVUs that were increased for mammography were increased because of those radiologists and their values, because of the compassion they had for their patients, our patients. And it was our patients who spoke up for us to a hostile crowd to let them know what we do and what it meant for them. And so our reputation as a specialty will affect our reimbursement. And that's hard to see on a day-to-day basis in the trenches. I get that, and I feel it too. And I hope I was able to show you a little clearer today why your values are much bigger than your RVUs. I thank you for your time and for the opportunity to serve.
Nicely done. Thank you. That's your staff. Thank you, Kurt. So let's stay on our pivot, let's stay on our spectrum. April of 2015, the SGR fix occurs. President Obama signs into law the Medicare Access Chip Reauthorization Act. The next speaker is Greg Nicola. Greg is vice president of the Hackensack Radiology Group. He's the chairman of the ACR's macro committee. He's been involved at the RUC. He's been at the table that Kirk just described. When I knew Greg was a real talent was after the first proposed rule dropped for what at the time was MACRA, now it's the Quality Payment Program. And the rule dropped about 5 p.m. on a weekday. We were actually at the RUC together, and the next day we're on a conference call, so we're trying to regroup and decide what we're going to do. And Greg starts his comments with the following. He says, "I do have to apologize, but I know the document's 2,400 pages. I've only read 800 pages of it." This was 12 hours later. So to Greg's credit, thank you. Please join me in welcoming to the stage Greg Nicola.
Thank you, Peter. Thank you very much. MACRA, 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 over and over again. So I want to start off with a story here. Has anyone ever received applause or standing ovation? It feels good, doesn't it? On April 18th, I got to witness American College of Radiology receive a round of applause from a group of people you wouldn't have expected. And it made me feel good. I was very proud to be a member of the college. I have no disclosures. See, this event occurred when I was giving a grand rounds. And, you know, the topic, I was the only radiologist there, and I was presenting R-Scan, and it happened to be at the Centers for Medicare and Medicaid Services for staff, medical officers of Medicare, and it was live, but it was also telecasted across the country to all the field offices. Here's a photo from the event. The back row are organizers of the event, some CMS staff. The front row are the 6 panel members. I'm there second from the left. We all had something in common. We all were participants and representing organizations that participate in the Transforming Clinical Practice Initiative, CMS. It's a grant release that tries to transform how we all practice before just doing payment models. It's actually giving you skills in the fee-for-service environment to transition to value-based care. And R-Scan is about that. It's about using collaborative activities to reduce unnecessary imaging and to encourage appropriate imaging. So after we all, and the 6 members here were the stars of the TCPI. There are actually 40 TCPI grant releases in the country, and these 6 organizations were chosen because they're the best of the best. So the American College of Radiology was already in rarefied air. Shortly after we all finished presenting, the Chief Medical Officer for Quality Improvement at Medicare, Dr. Paul McGann, got up, addressed the audience, and then suddenly asked me to stand up on behalf of the American College of Radiology, and then asked the audience to give us a round of applause. Can you imagine that? Medicare applauding the American College of Radiology. Why do you think that would be? Value. Everybody at the pinnacle of trying to transform our healthcare system thinks of this equation. And when Dr. McGann heard R-Scan, he immediately thought of value. R-Scan's activities include improving collaboration between physicians and encouraging appropriate evidence-based use of medicine. Those are directly addressing the quality category, increasing quality care to our patients. At the same time, R-Scan's mission is to reduce unnecessary tests and procedures, which lowers cost. That absolutely it makes value higher. It's there to absolutely maximize value. And why do I start off with this story? Because the fundamental equation of MACRA is this value-based equation. You cannot read the law without seeing this theme throughout it, over and over again. Now, there are flaws with this, and we all know them. For example, quality, ideally, that would be the outcome of the patient. Did the patient get better, worse, stay the same? And if they got better or worse, by how much? The problem is to measure that, the data science just isn't here yet. So we're stuck with surrogate measures. There's measures like very narrow scoped outcome measures. Or for example, there's lots of process measures. Did you do best practice as a surrogate for that might improve the patient's outcome? And sometimes there's patient surveys. Did the patient appreciate your care? At best, these are mediocre estimates of patient outcome, the real juice of what we're trying to get at. And at worst, they can be contradictory. It could be in the eye of the beholder. For example, a health system or a physician might value something different than what the patient is, and those measures are all over the place. And unfortunately, cost is not as simple to measure as we think it would be. There's all sorts of risk adjustment formulas, and it can cause all sorts of benchmarking problems. But we're stuck. Medicare truly believes in the PDSA cycle. They want something to be measured, they want some action to be taken, and they want to see improvement. And that's just the belief in the agency. So this is an equation we're going to be dealt with. We've been dealing with it through many different performance programs, but it's central to MACRA. And for MACRA, the measurement on how we perform on this equation has already started. It's this calendar year. The consequences of how we perform are January 1st, 2019. It's a 2-year delay. What are those consequences? Well, they're monetary. You'll have an adjustment to your income. They're also your reputation. This is going to be publicly available information on how you score on this program. It could be star rating, it could be the individual measures, it could be a point score. And it probably is going to be a combination of all those. So now I'm going to start to talk. I'm going to take you through 4 topics on MACRA. The why, the what, the but tomorrow. The why, what, but tomorrow of MACRA. Why is there MACRA? What is MACRA? But what is the college doing for us? And what does tomorrow look like? Why is this happening to me? The subtitle of my talk was the evolution of volume-based payments. I didn't make that title, but I try to see the evolution of volume-based payments. And really all it is more and more the money is being dumped into the healthcare system, to the tune in the United States of $3.2 trillion. And you've probably heard this before. That's the 5th largest economy if it was a standalone economy. And to put that in perspective, again, it's 17% of our GDP, but that's 7% higher than the average of other industrialized countries. That means those countries have 7% more of their GDP to spend on things that make them happy, like roads and safety and education and arts. It's a lot of money. The 17% number is not the one that alarmed me. It alarms me that it's still growing at 1.3% per year. By 2020, it's predicted to hit 20% of our GDP. This is just unsustainable no matter how you look at it. And we know the next phase of this evolution is going to be changing off of volume and switching to a value-based payment system. We know this already. It's written in stone. Everyone believes in this in Washington and in Baltimore. So let's look at the evolution of radiology. What we've seen is because there's more and more money in the system, we have fantastic machines and fantastic ability to read the images. And it's explosive what's happened there. So what's the next phase of this evolution? If the payment structure's changing, the evolution of radiology technology has got to change. Whether it's lower cost imaging or imaging that is just cheaper equipment, we don't know yet. But there will be a tug of war. There's certainly going to be precision medicine and the drive of technology that wants to keep this going, but it's going to have to slow down because of how the payment structure is going to go. Now, interesting, radiology is actually a particularly bad situation because of under the fee-for-service switch to value. And the reason is because if you look at the statistics in the United States, we perform twice the number of advanced imaging studies, and we have twice the number of advanced imaging equipment than the average of other industrialized nations. And all you have to do is plug what I just said in the value equation. If you know our quality outcomes aren't that much different than the rest of the industrialized world, that's about right, and you throw in double the number of advanced imaging equipment into the cost equation, you have a much lower value system. So there is no appetite at all for imaging growth. At the same time, Kurt made it very clear that our fee-for-service payment system is going to serve as a foundation for value-based payments. And I absolutely agree with that. We're seeing that everywhere. Bundled payments are really just fee-for-service with radiology fee-for-service payments inside them. And we're somewhat, comforted because we have reasonable fee-for-service payments that are being transitioned into these models. But imagine a situation where imaging growth returns. And then the legislators cut imaging in some capacity, and then we enter these value-based models that cut our volume. That scenario could be a reality because as of 2016, it looks as if imaging is growing again at 3%. We're back in a situation as there could be legislative cuts coming our way. No one wants to see imaging growing anymore. Topic 2, what? is happening. It's called the QPP, Quality Payment Program. This is a set of rules and regulations produced by Medicare that meet their statutory obligation under MACRA to change the ways they pay for physicians. And I think of it this way. Most physicians in this country are going to be stepping from fee for service onto a value escalator. Most physicians are going to get off at MIPS, which is the merit-based incentive payment system. It's a modified fee-for-service payment system tied to a performance program that has 4 performance categories. There are 3 that are the quality portion of the value equation, and that includes a quality performance category, an advancing care information category, which is how you use electronic records to communicate with patients or other referring physicians. And there's an improvement activity category. What are you doing in your practice to improve the care that you give your patients? And then, of course, we have to have the denominator of the value equation. And the denominator is a cost measure where there's 3 different cost measures. MIPS is meant to be uncomfortable. It's meant to be a place you don't want to stay. It has tournament-style income redistribution where the losers are paying the winners with an enormous amount of reporting burden, escalating income adjustments starting at 4% and then going up to 9% by the 4th year. To make it worse, our colleagues that either don't stop on this floor or get out of MIPS are incentivized to do so to the next level and join an APM. That incentive includes a 5% Part B aggregate bonus that's good for the first 5 years of the program. Also includes reduced reporting burden. And then eventually in 2026, you'll be paid more for everything you do compared to somebody back in MIPS. Now, is anything the government produces as easy as this slide? I've never seen it. Of course, there's more complexity here. The statute, or the legislators recognized that the bucket of APMs available to us, not all of them were created equal. Not all of them recognized value in the same way. So to correct this, they decided to just hand select a few of those APMs that they thought really epitomized value. And they labeled those advanced APMs, and only those models are really eligible for the incentives I just talked about. The statute defined 3 criteria for those models. They had to have upside and downside financial risk, they had to use electronic health records technology, and they had to report quality measures. To further narrow the bucket of folks getting the upside incentives for being in an advanced APM, the statute also divided those participants of advanced APMs into 2 types, a partial qualified APM participant and a qualified APM participant. The partial qualified participant and the qualified participant have slightly different thresholds on how many patients they see or how many dollars they bill Medicare. The partial QP only gets reduced reporting requirements. They do not get any upside money. The qualified participant gets the whole bucket. This is the advanced APM pathway. So what happens to the advanced APM participants that don't meet the partial qualified APM participant threshold? Or what about all those other APM models that didn't become advanced APM models? They get pushed back down the escalator into MIPS. They're competing with the rest of us. So herein lies the problem. We have a large number of physicians in MIPS that want to get out as quick as possible over into the APM world. Hardly any APMs, and we have a bottleneck. And to the statute and the legislators' credit, they recognize this. They also recognized after 7 years of APM creation and model testing that we're still left with almost nothing that is paying for value at this point. So they kind of waved a white flag and said, well, let you, me, our health systems, and specialty societies create their own models. And they gave it a name, the Physician-Focused Payment Model. Essentially, we are now all supposed to create our own models that meet the statutory requirements for an advanced APM and relieve this bottleneck. So I want to stop topic 2 right here. And before I go to topic 3, I want to stay on this slide. I want to add one other clinician type, and that's somebody who doesn't even participate in the QPP because they just don't see enough patients, and they can't really get a score in this program. Now, I love this slide because to me this sums up the entire program. We can all just take this slide home and you're done. You understand the whole thing. So here's how unbelievably complex the QPP regulatory language is. There are 5 different clinician types with rules for every clinician type for both individuals and then for groups. There are 3 different payment model types. There are rules on how to change between clinician types. There are rules for groups that have clinicians in multiple different buckets. There are rules for new physicians. There are rules for physicians that change taxpayer IDs, and on and on and on for 2,300 pages. And this is a yearly rule, meaning there's no way any of us could work ever again. We just have to read this. That's it. But, topic 3. We have the American College of Radiology. And its incredible staff and a dedicated group of volunteers, and in this specific instance, the MACRA committee. This committee took this monstrosity, and I'm going to read you just the name of the rule. Merit-based incentive payment system, MIPS, and alternate payment models, APM, incentives under the physician fee schedule, and criteria for physician-focused payment models. This would never be bought at Barnes & Noble's. No one would ever buy this. Here's the summary page, 220 words, 25% of it, new terms often defined by acronyms. I'm going to just cite a typical sentence in this rule. A MIPS EC can report using QCDR, QER, or EHR into IA, ACI, or quality. There are 4 people in this audience who understood what I said, and you don't want to have dinner with any of them. And this is the pinnacle of just stupidity. The title of the law, Medicare Access and CHIP Reauthorizations Act, acronym, MACRA, has an acronym, CHIP. Acronym with an acronym. But our staff and our volunteers took it and simplified it for all of us. They visited your state chapters, they gave national talks to you, created online content, webinars, everything we can do to educate the membership. We also work with other specialties and Medicare and slowed down the implementation of the law. The first 2 years are now called Pick Your Own Pace. If anybody in this audience feels you weren't listening, the first year, all it requires, 1 quality measure, 1 positive performance rate on 1 Medicare patient. That's it. You will not receive a negative adjustment if you do that. It's been slowed down that much the first year. We used evidence to influence policy. The advancing care information, how you use electronic health records, was finalized with measures that was really difficult or almost impossible for radiologists to do. It put a group of clinicians on a different playing field. Now, the statute did put special considerations in for us to receive an exemption, and we were able to use evidence to alter the threshold of that exemption. Medicare didn't accept all our ideas about the exemptions, and we wish we could have gotten more, but compared to what was proposed and what was finalized, we put a couple more thousand radiologists into the exemption bucket. We put members of our college on national committees. David Seidenworm is on a technical expert panel for measure development. And I don't know if any of you know David Seidenworm. I've worked with him many times, but I'll never forget at RSNA, I was asked to take a call with Medicare over measure development. And it was a little out of my purview. I'm more of a regulatory guy. And I'm on the phone. David's not on yet. They're asking me all these statistical questions. And thank God David came into the rescue, speaking a language I've never, ever heard before, but just an amazing individual. And then Zeke, our amazing commission chair, Josh Hirsch, and myself, were on a Medicare Resource Use Committee building the cost measures. We empowered you with our registries. The registry gives you access to high quality measures, bonus points on those measures, and most importantly, it gives you lots of feedback, unlike submitting to some of the Medicare mechanisms. You get quarterly feedback reports to know how you're doing on your quality measures, and you can actually make real-time implementation of quality improvement. RScan, we've already talked about it. But Medicare then again recognized it by giving you 7 opportunities to claim improvement activities in the MIPS category by using RScan. Not to mention whether you're in MIPS or APMs or wherever you are, if you want to add value to your healthcare system and reduce costs, the denominator, RScan's the tool. Tomorrow, I'm going to claim, just make a disclaimer here. This section's me only. The ACR is not on the hook for this. Okay, Zeke? Let's imagine 3 years from now. You're dictating structured reports with structured language with a scoring system a la lung rads, BI-RADS. It's seamlessly transmitted to the registry. We incorporate EHR data, and we can finally match outcomes of the patient for what we're doing on our end. This is a word of caution. Imagine the future, you've been working with a urology group for 30 years. They've been referring to you. They decide they're going to be in a physician-focused payment model, which requires them to have anybody participating with them at a certain threshold has to use electronic health records technology. And your group hasn't adopted electronic health records technology. Guess what? They're going to find another radiology group. It's part of the statute. They need you using electronic health records. I know they're bulky. I know they're clumsy. They're in everyone's future, and we have to adopt them. Let's say also in the future that PACS and EHR are significantly more integrated. We can find activities that we do that are add value in the electronic health records environment. It's just a short hop to get measured development, meaning we are in the ACI, the Advancing Care Information category, which, believe it or not, gets rid of the non-patient-facing clinician language that we are all now burdened with if we're out of this category. This silly category is how we get the language of non-patient-facing clinician. Imagine in the future, you're a breast imager. You have a screening mammogram, looks like a mass. Diagnostic mammogram, looks like a mass. You no longer need to call anybody to do the ultrasound, MR, biopsy. Why? Because you took accountability and you have a new payment model that maybe pays you care coordination fees to do it all yourself. If the biopsy comes back positive, you work with the primary care doctor and the patient to make sure they're getting to a surgical hands. If it's not, you don't need a surgical consult. This could be possible with a physician-focused payment model, which are judged or evaluated by the Physician-Focused Payment Model Technical Advisory Committee, PTAC, in conjunction with the CMS Innovation Center. This is not the future. This could be today. Let's put you in something in perspective here. The MACR committee with staff and volunteers had roughly 35 people working on the legislation at any one time in the ACR. But what if we all engaged and used social media and reacted to quality measures when we put them out there? Or if you're using a quality measure in your practice that you think would be a national quality measure and you bring it up on Engage. Or if you have a payment model you think is a good idea for us and you bring the topic up on Engage. Remember, I call this era, this is, to me, the era of the couch potato advocate. 35,000 minds are going to be better than the 35 that worked on MACRA. Thank you very much.
Nicely done. So I'm going to close our first part, but I want to give you a preview, if I may, of what we have in the second part. I'd like to start pretty close to 3:30. At that point, we're going to make our Thorworth Award to my colleague and good friend Jim Rawson. And then I'm going to welcome our keynote speaker, because there was a theme that came through in every speaker that we heard so far today. That's the importance of collaboration. Collaboration of the Economics Commission with the other commissions in the college. And I'm going to bring the chairman of the Informatics Commission, Keith Dreyer, to the stage to talk about informatics solutions in the payment landscape which was described today. We'll follow that with two speakers. We will be sure to close promptly by 5 p.m., if not sooner. But I do want to take a few minutes before we take our break, probably before 3 o'clock, but here shortly. I want to kind of wrap up this session because I want us to think about the topics were just discussed. I want us to think about that spectrum with which I opened. that spectrum where we talked about volume. Our speakers talked about fee-for-service. Greg quickly pivoted to value. But it is not a concrete step. It is not an escalator. It's a spectrum. It's a blend. It's a transition. These are the speakers. These are the individuals. This is our college. This is our staff that are helping our members, those touched by the radiology profession, to navigate that spectrum. And I'm going to borrow what Bibb Allen said during his presidential address yesterday. And that is our challenge. Our challenge is to stay on top of the curve, to stay ahead of the curve, but to do it responsibly, to do it in an informed manner. Okay, Greg described the PTAC, the Physician-Focused Payment Model Technical Advisory Commission. They're meeting. They're talking about new payment models. But for us to be on top of the curve, to us to walk into that forum and talk about a radiology-specific or radiation oncology or interventional radiology-specific payment model requires thought. It requires a purposeful discussion. It requires input from everyone in this room so that we make sure that that's workable, that we make sure that it's possible, not just for the radiologists, not just for the facilities, but for the patients we serve. Bibb used the example of not getting too far ahead of the curve. And I'm going to take that to heart yesterday. And we think about it on the commission all the time. We talk about our immediate steps. We think short term, we think intermediate term, and we think long term. So I love what Dana presented early in our session, because really she showed that when we talk about code creation, and we talk about creating CPT codes to describe services, sure there's a descriptor, and sure that descriptor says mammography, but underlying that descriptor is what we do every day. She hands the ball to Kurt. Kurt walks into that room and he builds on that theme which was already started at the CPT editorial panel. And that is the value being influenced favorably by what we do every day. And I want to re-emphasize a point that Kurt made. And the fact of the matter is, CMS is in the room. They're in the corner of the room, or corner of the table, excuse me. They're listening to what we say, and those messages that we communicate on behalf of our presentation and our specialty and our profession make it back to Washington. They make it back to Baltimore. They influence policy. They influence our role on the spectrum that is volume transitioning to value. We'll take a break. We'll come back promptly at 3:30. Keith Dwyer will come on shortly thereafter. We're not doing a formal Q&A this morning or this afternoon, but the faculty have volunteered to stay up here. So anyone who wishes to visit with them, please do. Thank you for your attention for part one. We'll see you at 3:30 for part two. Thank you.